regional enteritis or Crohn's disease or granulomatous colitis. Regional enteritis commonly occurs in adolescents or young adult but can appear at any time of the life. It is more common in women and it occurs frequently in the older population between the ages of 50 to 80. It can occur anywhere along the GI tract, but the most common areas are the distal ileum and colon. The incidence of Crohn's disease has risen over the past 30 years. Crohn's disease is seen in 2 times more often in patients who smoke than in non-smokers. Pathophysiology. Regional enteritis is the subacute and chronic inflammation that extends through all layers, that is transmural lesion of the bowel wall from the intestinal mucosa. It is characterized by periods of remissions and exacerbations. The disease process begins with edema and thickening of the mucosa. Ulcers begin to appear on the inflamed mucosa. These lesions are not in continuous contact with one another and are separated by normal tissue. Fistulas, fissures, and abscesses form as the inflammation extends into the peritoneum. Granulomas occur in one half of the patients. In advanced cases, the intestinal mucosa has a cobblestone appearance. As the disease advances, the bowel wall thickens and becomes fibrotic, and the intestinal lumen narrows. Diseased bowel loops sometimes adhere to other loops surrounding them. Clinical manifestations. In regional enteritis, the onset of symptoms is usually insidious with prominent lower right quadrant abdominal pain and diarrhea unrelieved by defecation. Scar tissue of the formation of granulomas interfere with the ability of the intestine to transport products of the upper intestinal digestion through the constricted lumen, resulting in crampy abdominal pains. There is abdominal tenderness and spasm. Because eating stimulates intestinal peristalsis, the crampy pains occur after meals. To avoid these bouts of crampy pain, the patient tends to limit food intake, reducing the amounts and types of food to such a degree that normal nutritional requirements are not met. The result is weight loss, malnutrition, and secondary anemia. Ulcers in the membranous lining of the intestine and other inflammatory changes result in a weeping, swollen intestine that continually empties and irritating discharge into the colon. Disrupted absorption causes chronic diarrhea and nutritional deficits. The result is the person who is thin and emaciated from inadequate food intake and constant fluid loss. In some patients, the inflamed intestine may perforate, leading to intra-abdominal and anal abscesses. Fever and leukocytosis occur. Chronic symptoms include diarrhea, abdominal pain, steatorrhea, anorexia, weight loss, and nutritional deficiencies. Abscesses, fistulas, and fissures are common. Symptoms extend beyond the GI tract and commonly include joint involvement, that is arthritis, skin lesions, example erythema nodosum, ocular disorders, example conjunctivitis, and oral ulcers. The clinical course and symptoms can vary. In some patients, periods of remission and exacerbation occur, but in others, the disease follows a fulminating course. So once again, lower right quadrant abdominal pain, diarrhea, crampy abdominal pains, because of lack of nutrition, patient will be thin, emaciated, and intra-abdominal and anal abscesses will form. Steatorrhea, anorexia, weight loss, and nutritional deficiencies. Assessment and diagnostic findings. A proctosigmoidoscopic examination is usually performed initially to determine whether the rectosigmoid area is inflamed. A stool examination is also performed. The result may be positive for occult blood and steatorrhea, that is, excessive fat in the feces. The most conclusive diagnostic aid of regional enteritis is the barium study of the upper GI tract that shows the classic string sign on the X-ray film of the terminal ileum, indicating the constriction of the segment of intestine. Endoscopy and intestinal biopsy may be used for confirmation of the diagnosis. A barium enema may show ulcerations, the cobblestone appearance described earlier, fissures and fistulas. A CT scan may show bowel wall thickening and fistula tracts. A complete blood cell count is performed to assess hematocrit and hemoglobin levels, usually decreased, and the white blood cells count may be elevated. The sedimentation rate is usually elevated. Albumin protein levels may be decreased, indicating malnutrition. So, proctosigmoidoscopy, stool examination, barium study, X-rays, endoscopy and intestinal biopsy, barium enema, CT scan, complete blood cell count, then ESR, albumin and protein levels. Complications of regional enteritis include intestinal obstruction or stricture formation, perianal disease, fluid and electrolyte imbalances, malnutrition from malabsorption, and fistula and abscess formation. A fistula is an abnormal communication between two body structures, either internal, that is between two structures, or external, between the internal structure and the outside surface of the body. The most common type of small bowel fistula that results from regional enteritis is the enterocutaneous fistula, that is between a small bowel and the skin. Abscesses can be the result of internal fistula tract into an area that results in fluid accumulation and infection. Patients with regional enteritis are also at increased risk for colon cancer. Treatment, same with the treatment of inflammatory bowel disease. Medical treatment for regional enteritis is aimed at reducing inflammation, suppressing inappropriate immune responses, providing rest for the diseased bowel so that healing may take place, improving quality of life, and preventing or minimizing complications. Most patients maintain long-term well-being interspersed with short intervals of illness. Management depends on the disease location, severity, and complications. Nutritional therapy, oral fluids, and a low residue, high protein, high calorie diet with supplemental vitamin therapy and iron replacement are prescribed to meet nutritional needs, reduce inflammation, and control pain and diarrhea. Fluid and electrolyte imbalances from dehydration caused by diarrhea are corrected by intravenous therapy as necessary if the patient is hospitalized, or by oral supplementation if the patient can be managed at home. Any foods that exacerbate diarrhea are avoided. Milk may contribute to diarrhea in those with lactose intolerance. Cold foods and smoking are avoided because both increase intestinal motility. Parenteral nutrition may be indicated. Pharmacologic therapy, sedatives and antidiarrheal and antiperistaltic medications are used to minimize peristalsis to rest the inflamed bowel. They are continued until the patient's stool approaches normal frequency and consistency. So, newer sulfur-free aminosalicylates and corticosteroids, prednisone orally or topical, rectal administration corticosteroids, immunomodulators, azathioprine, that is Imuron, and surgical management. When non-surgical measures fail to relieve the severe symptoms of regional enteritis, surgery may be recommended. The surgeries are that is surgical procedure known as fecal diversions, total colectomy with ileostomy, total colectomy with continent ileostomy, total colectomy with ileoanal anastomosis. Newer surgical procedure developed for patients with severe regional enteritis is intestinal transplant. This technique is now available to children and young adults and middle-aged adults who have lost intestinal function from disease. Although not a cure, this procedure may eventually provide improvement in quality of life for some who are terminally ill. Thank you.